Thank you. Thank you, Dr. Ron, for your introduction, but most importantly for your leadership at University of Arkansas Medical Sciences. I'm grateful for this forum and this venue in order to talk about healthcare and the future of it in Arkansas. And I am delighted that there's a few people interested in this topic. And I think the fact that you're here reflects the importance of this issue for our state, and I'm grateful for your presence here today. I'm particularly glad to see so many legislators that are in the room. And I wanted to recognize President Senator Jonathan Dismang for his leadership on the Senate side, been a great partner and leader in this effort, as well as Speaker Jeremy Gillum, who likewise has been a key player in the development of this issue and will be in the future as well. I also want to recognize Senator Cecile Bledsoe, who is chairman of the Senate Health Committee, as well as Representative Kelly Link, chairman of the House Health Committee, who play key roles as we look to this issue in the future, and thank you for your guidance on this issue as we have prepared for this. I'm delighted today to introduce the new Surgeon General of Arkansas, Dr. Greg Bledsoe. Dr. Bledsoe, go ahead and stand. I'm a newly minted governor. He's a newly minted Surgeon General. He just got sworn in about 30 minutes ago. And so thank you for being here, Dr. Bledsoe. You'll be a key advisor as we look at health care in the future. I want to start by thanking the physicians, the nurses, the health care providers who have labored in the trenches for health care in Arkansas and improving our quality of life, working with those that need better health care. You have been on the front line, you're committed, you're passionate, and I'm grateful to you. And that's important to say at the outset because you came out of your training with a heart for patients, and all of a sudden you find yourself inundated with government regulations and finding yourself having to spend hours and hours and hours each day and week in matters that do not deal with patient care. And so I'm grateful to you, I'm thankful to you, and your work needs to be recognized and your sacrifice. A college professor that I had always gleefully began each lecture with the phrase, "A moment of review and then on we go." And that's important in history, but I think it's important today. And so I want to spend a moment in review and then we'll talk about the future. And if you look at the review that we need to talk about in recent history in healthcare, it all starts with the Affordable Care Act. The Affordable Care Act had four major parts, very simply articulating it. One, it was the individual mandate that every person had to have insurance. Secondly, it was the employer mandate that employers that were in a certain category had to provide insurance. The third part of it was the health insurance exchanges in which middle income and others can go on the marketplace and obtain insurance, and if you're in the middle income category, you will be subsidized with taxpayers' money. The fourth part of it was the Medicaid expansion, which led us to the debate that we're having today. I, of course, along with many others, and we have varying views in the room, but I opposed the Affordable Care Act. I did because the individual mandate I thought was an infringement upon freedom. I thought the employer mandate was not good for business and the growth of jobs in America. I thought overall it was taking control away from physicians and healthcare professionals and got the government too much involved. But guess what? I lost that debate. And I urged that that law be challenged in the United States Supreme Court, and it was challenged and it was heard. And the Supreme Court, to our surprise, affirmed all of the Affordable Care Act except for one part. And that was the Medicaid expansion that was left to the states to debate and determine. And so all those who did not believe it was the right direction for America was left with the frustrating option of what do we do with this? And Arkansas was the center point of this debate in Medicaid expansion. And we came up with our own creative options, and this led to the private option solution. And it was innovative that I will talk about, but that whole solution and the Medicaid expansion that we transformed into private option in Arkansas has divided our state and dominated the political debate. My nephews illustrate that. I have two nephews in the General Assembly. Both are conservative, both are thoughtful, and one voted for the private option and one voted against it. Now, that could have been mirrored all across the spectrum of political debate in the legislature. This morning, I want to share my perspective on the private option. I want to talk about its benefits, its future costs to the state. I want to talk about the profile of those in the private option and how I've worked hard to obtain that profile. You've heard me talk about that. And then I want to talk about where we go from here. Now, I know you came here today to hear one simple statement as to where we go from here. Please be patient. Because the facts and the data are important for the conclusion and the direction as to where we go. So I want to spend some time on the background of this and the pros and cons because it helps shape the debate for the future. And let's look at the private option. It is innovative. The sponsors of the private option legislation should be recognized for their hard work in fighting for a solution with market principles and some conservative principles that are in play. The U.S. Supreme Court Justice Louis Brandeis, in a famous decision, described how the states are a laboratory of experiments and a laboratory of democracy to look at innovative ideas. That is appropriate, and that's what we have done in Arkansas. But those who oppose the private option were just as equally committed and had a different perspective. They were wise in asking questions about the cost. They were wise in saying, can the federal government keep its promises? And can the state of Arkansas afford this innovation and expanded health care? Two sides of the same debate coming from good directions, conservative convictions, reaching different conclusions. And I recognize that good people were on both sides of this debate. And we're trying to struggle as to how the state of Arkansas should navigate this issue. Over time, it became clear once the private option was being implemented that there were two key benefits for the state of Arkansas. One is the obvious, that you have approximately 210,000 individuals in Arkansas that have never had health insurance before, that have been transformed, have access to health care, and have health insurance they've never had before. That is a benefit to the state of Arkansas. Secondly, you have a benefit to urban hospitals, such as UAMS, and rural hospitals all across this state. Those two benefits are facts that we cannot deny, should not deny, and should rejoice in, that they've had that benefit and expanded health care as well. But I also, we have to recognize that there's other costs that I'll talk about in a moment. The facts, though, that outline what I just spoke about in terms of the benefits is that there has been a 10% drop in the uninsured in Arkansas. We have our Arkansas hospitals saw a reduction of $69 million in uncompensated care during the first half of 2014 compared with the same period of time in the previous year. Many of these rural hospitals, by the way, are listening today to this broadcast by remote broadcast. I welcome them to this. I've been in your communities and understand what you've communicated to me as to the importance of the private option to the economic viability of the hospital that serves your community. The number of hospital visits by the uninsured patients fell by some 47%. These equate to greater financial benefits to our rural hospitals. The state has also been a beneficiary of the private option in terms of shifting more of the Medicaid cost to the federal government. And it's still taxpayers' money, but it's been a shift of costs and it's been a benefit to our budget. In 2015, the state's going to save roughly $88 million, which is a combination of shifting traditional Medicaid in some categories to the private option, which is 100% paid for at the present time. It is also a savings because of a reduction of uncompensated care payments to several agencies, from UAMS to the Department of Corrections, the Department of Health, community health centers, has saved about $33 million. All of that is taxpayers' money from different pockets and different places, but it has made a benefit to the state of Arkansas in terms of our budget. But the long-term cost and the solutions in terms of funding remain legitimate questions. And the facts are, on that side of the fence, that the required match of 10% for the private option when it comes into full responsibility of the state will cost the state over $200 million. To put this into context, that's two $100 million prisons. Now, I know that doesn't get anybody excited, but that $200 million is also almost 1/3 of the budget for all state higher education institutions. $200 million, almost 1/3 of our general revenues that go to higher education. And so there are budget consequences real to our institutions and education and other services that we need, looking down the horizon, that $200 million cost. And then there are unintended consequences to the private option. I don't know that anybody anticipated, at least spoke about, the fact that parolees coming out of prison are put on the private option. That's a good thing, but it is not something we talked about and was aware of at the beginning. Well, we were not aware that many charitable and volunteer health care programs in this state would no longer exist. One was called Operation Walk, in which surgeons donated a weekend to provide free knee and hip surgeries to those who had no insurance and could not afford them. It is the finest tradition of the medical profession. Arkansas was among the nation's leaders in the number of free surgeries our doctors provided. This past December, there was no Operation Walk in Arkansas. Why? Because the private option made that unnecessary and irrelevant. This story is the same with many charities across Arkansas. What once was done by medical volunteers and charity is no longer necessary. Why? The service was transferred to the government. Now, some see this as a good thing, that the government can do it well. It takes the burden off of our medical professionals who are volunteering so much time. Others worry about this shift to the government sector. But most importantly, as we look at the private option and the impact of it, whether you're for or against the private option, there is a deep abiding concern for those without health coverage. In other words, the human side tugs at our heartstrings and rightfully is a factor in this debate. Donna Foster is a 44-year-old mother of two who makes $8.65 an hour as a caregiver attendant for the elderly in Morrilton. She typically works 40 hours a week. She is a single mother. She divorced when her now grown children were small. For at least 10 years, she could not afford health insurance. Donna suffered from high blood pressure. She was able to purchase generic blood pressure medicine, but she often could not afford the $186 it costs for an office visit and checkup. Suspected that her blood sugar was high, Donna was supposed to be tested for diabetes. She couldn't always afford that either. Recently, she secured health insurance through the private option. The first thing she did was to go to the doctor, get back on her blood pressure medication, and get tested for diabetes. She tested positive, and now she is being treated for it. Health insurance made a difference in her life. And also of importance, it most likely saved future medical costs to the state of Arkansas because of the care that she received. This debate that we're going through about the future of health care and the private option is not unusual in American politics because it comes down to a simple question of, do the benefits that we recognize exist outweigh the cost? While the question was basic, a divide was created in our state. Over the course of the last 2 years, our state has been caught up in the debate. We have been wrapped around the political axle. The phrase private option itself has become politically toxic, so much so that it's almost impossible to have a constructive conversation about health care reform in Arkansas without passions rising and folks taking sides. Ladies and gentlemen, debate is good. Conviction is good. But let's remember what we are trying to do here, and that is to build a healthy Arkansas, not politicize a phrase to the point where its very utterance becomes an invitation for debate and fight. My goal is to broaden the debate to the larger Medicaid budget and to accomplish reform in a way that works for Arkansas. The goal is to have an affordable, competitive, market-based solutions on the conservative principles of choice, competition, improved quality of care, and consumer responsibility. To accomplish that, we have to reach agreement. The challenge for us in Arkansas and in this political environment is that agreement is defined by 3/4 vote, or a supermajority in the Arkansas General Assembly. Now, I've mentioned also the importance of the profile of those on the private option. I've talked about this a long time, and the information was not available until very, very recently. Well, now we have some data to share. About 40% of the enrollees at the time of application for the private option showed no income. That means they were unemployed, had no income, 40% on the private option. 70% of those on the private option were employed at some point in time, which tells me they're trying to get a job. That tells us that most are working but cannot find the steady work that is needed. Young people were more likely to have work than those that are over 45. Women were more likely to have work than men. This tells us that the older male population should be targeted for work. These might be men who've been laid off or need to learn new skills to transition into another career. It's interesting that 10% of those in the private option are considered medically frail, and that population seems to me, if the private option ended, would probably go back to the traditional Medicaid and qualify for that. This is all helpful information because it's the data that guides our debate in the future of health care reform and decisions that we have to make in Arkansas. Now let's talk about the future for a moment. And a large point of what I'm trying to say is that the private option is a small part of the debate, but a very large part of the discussion. And I have here this chart looking at the future. And if you look at the future in 2021, the year in which Arkansas fully has to pay 10% of the private option cost. And that, as I've said earlier, is over $200 million for Arkansas. This figure, $221 million, this is estimated, but that is the red part of the pie. So the red portion of the pie that we have to take in general revenues for matching funds for the private option is this portion of the pie. That's been the focus of our exclusive debate. But look at the blue, how large that is. And this is the $1.8 billion that's devoted from general revenues to our traditional Medicaid budget. And so if we're going to look at the future cost to this state, would it not be wise to consider the entire Medicaid cost and not just focus on one aspect of it? And that is why when I mention broaden the debate, it becomes to the fact of cost effectiveness and the $2 billion of general revenues that are at risk in the future for the state of Arkansas. And so that is important information. So if you combine the data on the profile of the participants of the private option with the knowledge that our future liabilities as a state are more dependent upon the entire Medicaid budget, then you have a starting point for future reform. And I believe that there are some principles that should frame the debate for the future. And one of them is work and responsibility. I want our social programs in Arkansas to be an incentive for people to work versus an incentive for people not to work. And Arkansans want to work. And when they work, they should get ahead. And when they work real hard, they should be able to climb up the economic ladder. And I believe the vast majority of Arkansans want to work. Nobody who is able to work wants to stay on government health care. They want a job. And while it's encouraging to see so many folks now insured who did not have health insurance before, I'd like to see us reduce that number, and we can reduce that number as we move people to work and they move up the economic ladder. Secondly, we need to have incentives for preventive care. There's a lot of opportunities there, but people need to own more responsibility in their health care decisions. They need to engage in preventive care, and we need to incentivize that in the reform that we have for the future. We need to remember the role and emphasize the role of the private sector and charity care. And it's not any group responsibility, but it is all of ours collectively. It is a public responsibility, it is a private sector responsibility, and there is a role of charity care as well. As a rural state, we have to remember as a principle that we have to have access to health care in the rural areas of our state. And that involves technology and telemedicine so that we can work to make sure that those in the less affluent areas of our state have access to the highest quality health care. Through telemedicine, a knee and hip specialist or neurologist in Little Rock or Northwest Arkansas can be brought to somebody in the Delta. We can share our expertise across this state. We have to continue to use technology to assure quality health care throughout Arkansas. And then a principle that should guide us is cost control. Look at the history of the cost of our social programs in terms of health care. 50 years ago this summer, the Medicare and Medicaid programs were signed into law by President Johnson. Nobody, not even conservatives, thought those two programs would grow so uncontrollably. In fact, in 1965, Medicare had been projected by a House committee to cost $12 billion by 1990. What did it actually cost? $110 billion. How's that for government estimates? And so you look also at the individual and group insurance markets. Those costs have skyrocketed. Many cannot afford their individual insurance and they go without health care. And for that reason, some 60% of personal bankruptcies filed in this country result from medical bills. Clearly, our health care system needs more attention and continued efforts at reform. And finally, very importantly, we need to have flexibility and reform at the state level, the laboratory of innovation. And we need to make sure that is comprehensive in terms of the entire Medicaid reform efforts and our entire Medicaid budget. So today in Arkansas, we are at a juncture. Which way do we go? We recognize that hospitals and healthcare providers cannot face a traumatic cliff every year when it comes to renewing the private option and what's going to happen in the Arkansas General Assembly. We need more consistency, we need more reliability, we need more predictability so that we can plan and do strategy in terms of health care. Secondly, we want to have a health care system that we can afford, that we know is not going to absorb continued greater amounts of general revenues. We want to have a system that looks for a way to help those Arkansans through the private option or covered by the private option and to assure access to health care in the future for those. We are Arkansas. We are Arkansans, and the characteristic of our state is that we look out for each other. Recently, I received a letter from a woman named Christine Smith, who lives in Fayetteville. Christine began the letter by saying, "I'm writing to you as an Arkansan, but more importantly as the mother of a 19-year-old son who has just been diagnosed with cancer." Christine's son went in for a regular physician's visit with the doctor when the doctor noticed that his neck felt a little swollen. They ran some tests and discovered that the boy had a tumor. They performed surgery, removed the tumor, and followed up with treatment. It worked. Christine's son is now finished with his treatment. He's feeling well, and he's at the University of Arkansas studying environmental science. When I received Christine's letter and heard this story, I immediately thought that she must have been insured through the private option, and that's the case she is making. And she's urging me to keep the health of all the citizens in mind. But the Smiths had insurance. So the point of her story was not for herself, but she was writing because she was going through this ordeal. She was thinking about others that did not have the benefit of insurance. She couldn't imagine how families do it who don't have coverage. That's just like an Arkansan, to think about others who may not have the same health care coverage. And so I want to assure Mrs. Christine Smith and all Arkansans that I want us to have a health care system that is compassionate, affordable, fits Arkansas, and provides access to care. I agree with you, Christine. And now is the time for me to be more specific. As governor, I will ask the legislature to take the following action. First of all, to fund the private option this fiscal year and continue it through December 31, 2016. This avoids harm to the 200,000 plus on the private option, and it assures our hospitals and providers of financial stability. Secondly, I'm asking the legislature to create a health reform task force that will make recommendations for the future. And the purpose of this task force is to find an alternative health coverage model to ensure health care services for vulnerable populations currently covered by the private option. So hear me clearly. We're going to continue the private option through 2016, create a health reform task force that will make recommendations for the future, and that will include a compassionate and reasonable and cost-effective response for care of those that are currently on the private option. The task force should also be charged with exploring and recommending to the legislature options to modernize the entire Medicaid program currently serving the indigent, aged, and disabled. Guidelines should govern any task force. And the guidelines I would suggest to the legislature should include, among others that they very well may add, and that is to minimize or eliminate the need for the state to raise additional general revenues for continued investment in this. Obviously, you have to keep up with inflation, but you want to minimize or eliminate the need for the state to raise additional general revenue for those purposes. Secondly, more federal flexibility in managing the state Medicaid program. Flexibility is critical. We fought for that. We want to continue to fight for that, including consideration of block grant type waivers or authority so that we can have the maximum amount of flexibility in Arkansas. And then to strengthen the employer-sponsored health insurance market, to increase employment of healthy recipients of taxpayer-funded health care services, to encourage the work as they receive that benefit for the working poor, to increase accountability and personal responsibility for healthy behavior of beneficiaries, and finally, to provide access to health services in rural areas of the state. These are some of the guidelines that should govern the task force that will go to work. The timing of this task force is urgent, it is important, it is critical, and it's got to move quickly, although thoughtfully and comprehensively. A report will be required by this task force by the end of 2015. They go to work. By the end of 2015, we've got to have some answers back and some recommendations, because we need to allow time for legislative action so that we will have clear direction for our hospitals, our providers, and those that are currently covered for the future. And that would be to allow time to request necessary waivers and approvals from the federal government as well. so that we can have our solutions in place by December 31, 2016. I will further direct the Department of Human Services to immediately begin a formal assessment of the opportunities available to reform our Medicaid services to better serve our high-cost, high-need populations. And secondly, to utilize private sector expertise to identify and prevent waste, fraud, and abuse in our Medicaid services. This information that will be developed on the executive side through Department of Human Services will be beneficial to the legislatively driven task force. Data will drive solutions. Now let me emphasize to everyone here and that's listening that in regard to the private option, it is time to close this chapter and to start a new one. It is a new day for health care in Arkansas, and I pledge to work with you to find the right solution for all Arkansas. And while we are turning the page and beginning a new effort, our innovative efforts in Medicaid reform will continue. And by that time, December 31, 2016, we will have the recommendations of the task force. We will have a plan in place that assures a continuity in health care that is right for Arkansas and a plan that we can afford. I want to end by talking about the recent meeting that I had with Secretary Sylvia Burwell in Washington, D.C. This was an important meeting, and I asked President Dismang and Speaker Gillum to designate one on each of their respective houses to join me for this meeting with Secretary Burwell. And I was delighted that we had Representative Kelly Link and we had Senator Jim Hendren join me for this meeting, as well as our new Surgeon General. And as we met with Secretary Burwell, we made the case that we needed more flexibility in Arkansas to determine our own direction of health care and to take this initiative and this idea of the entire Medicaid budget and say we want to work together as a team in Arkansas to determine the direction of the future in cost-effective ways, but also keeping in mind the necessity of the care of those that are less fortunate. And as a result of that meeting, Secretary Burwell was responsive, but we know what's in writing is what's important. And so just earlier today, I received a letter from Secretary Burwell that we will be prepared to release following these remarks. Dear Governor Hutchinson, and I'm not going to read the entire letter, but in summary she says, I was pleased to learn of your commitment to an effective and affordable approach to coverage for the newly covered adults beyond the current 3-year term of Arkansas's Health Care Independence Program demonstration or private option, and to also move forward on major delivery system reforms that would apply to the larger Medicaid population. She goes on to say, we also understand your desire to encourage employment, and we commit to work with you on how you might achieve this objective while ensuring access to health coverage for eligible individuals. She goes on to say, we appreciate and support your desire to avoid a piecemeal approach to reform and look forward to working with you on a potential broad block of changes that could lower costs and improve access and quality in ways that best meet the needs of your state. I will release this letter signed by Secretary Burwell shortly after this meeting. I don't want to take it out of context, but those are some of the highlights of the letter. And I'm gratified that there is an increasing willingness to give the states more flexibility that will help guide our decisions in this health care reform task force. Thank you for your patience as I went through this presentation. I noticed that there was not resounding applause at any point during the speech. And I think that simply means that we recognized how important it is and that whatever we do, we're going to get criticized, we're going to get applauded by various sides. But what I firmly believe is that we, because we've turned the chapter We're creating this task force. We've set the stage for the future, that we're going to be able to do something great for those that are in need of health care, for our great institutions of health care in Arkansas that are providing great service, and that we're going to really set the stage for an affordable system for the future of our state. I'm an optimist. I'm an optimist that the good people in this room will be able to work together to accomplish great things for our state. Thank you very much.